no questions. We covered the basics of the actual opioids, how they work, all of that. We'll get into how we actually use them, which is important in terms of talking about our the prescription assignment, right? We were talking about, we have medications we're going to be given for mild pain, moderate pain, severe pain, etc. So how do you pick an agent? Like, what do you think? It depends, right? It depends is usually the right answer for a lot of the situations here. So a lot of it can be based on the intensity of the pain they're actually experiencing, and especially if you work in somewhere like surgery or cancer, you'll get a feel for how painful things are, right? So for instance, like, a tonsillectomy, less painful than something like a scoliosis procedure. That's pretty obvious, but you'll get into kind of those nuances there. Typically, if it's more persistent pain, more chronic pain, we're going to get into using more long-acting formulations, and that's good for what? Just a baseline basal amount of pain the patient's experiencing, and then you'll have sort of immediate acting drugs on top of that for all that breakthrough pain, right? They get up, they walk around, they have more pain. That's where we're going to give them a short-acting medication there. Now, route of administration is also going to be important here. So, for instance, for more, say, mild to moderate pain, which route do you think you can get away with? Most often oral is going to be the way to go, right? And then when you get into more severe pain, you want something that's going to be a little faster acting, a little more quick to the system. That's where you can get into more parenteral dosage forms, right? So, or if the patient's not able to take anything orally, that's where parenteral dosage forms like intramuscular, IV is going to be the way to go there. Typically, especially if you're thinking about like in the inpatient sort of setting, like you imagine like our post-operative kid in that setting there, if you're thinking for moderate pain, you'd be thinking more kind of what route? You could, normally what I end up seeing a lot of times would be like an oral dosage form for more of that moderate pain, more severe pain, right? That's where you're thinking like on a number scale of 1 out of 10, that's like your 7 to 10 sort of range there. That's pretty severe pain. You probably want to give something what route? Probably IV in those cases there, right? So it's not uncommon that you may see order sets that would come out where it would have, say, for like mild pain, a 1 to 3. You maybe give them oral Tylenol. Maybe for like a 4 to 7 or 4 to 6, you give them, say, like an oral opioid, and then from 7 to 10, you give them an IV opioid. Or for that moderate one, maybe you just give them an NSAID instead, right? So it just depends on the setting there and kind of what pain the patient's actually experiencing, what they respond to. Generally, though, if you don't have to have an IV, oral is going to be fine for the most time. You just know it takes a little longer to kick in there. But certainly we'll use other routes too if we don't have an IV. If I have a kid who comes in and they have, a fracture and they have no IV placement and they're really kind of anxious and they're needle phobic, we can give intranasal fentanyl. That's a really good option for a lot of those kids. It'll absorb to the nasal mucosa, bypass the liver, and it works quite well for them. Typically, if you're using a transdermal dosage form, like a Duragesic, which is a fentanyl transdermal patch, those are for just long-acting use, right? And so sometimes what you'll see our patients will do is that they'll be like on a continuous IV drip of, say, something like fentanyl, and they'll actually transition them over to the transdermal, right? But what's the thing to think about in terms of onset for like a transdermal medication? Is like immediate? Takes a while, right? Because it has to diffuse through the skin. So oftentimes what we'd actually do is we would have a patient on IV drip of fentanyl. We would then put the patch on them concurrently, and then about, say 12, 24 hours, you cut down on the fentanyl drip, and then another 12, 24 hours later, you cut off the drip, and then the patch itself should be kind of working at that point, right? So it seems like you're having a duplication. It could be dangerous, but you're kind of titrating the drip down so that way the patch has time to kick in there, right? Anyway, other things to consider is that, like I mentioned, it's kind of like a magic show. You don't want to start off by sawing your assistant in half. Like, start off low, go slow, and you can work your way up, right? You always give another dose of a medication if you need to. But, over-medicating them can lead to some issues, as we're going to see here in just a minute when we're looking at some of the ways we can deal with those toxicities. So, you guys ever heard of a PCA before? So it stands for patient-controlled analgesia. Basically, it's like the patient has a button that they can press. This is important, especially if you're dealing with like your post-operative kids. You'll see this. We do this quite frequently in the post-operative setting in order to allow for patients to control their own medication to an extent. What do you think the benefit of that is? They control, so that when they feel like they have a little bit of empowerment, because they say like, I'm hurting, I'm going to press a button and give myself some extra medication, I feel better now. What other things do you think that could be the benefit? Maybe less nursing calls, so maybe your nurses are able to go deal with other patients instead of having to give that drug to that particular one. Anything else?
You're only getting pain meds when the
Exactly, yeah. Yeah, and it's based off their subjective assessment of that too, right? So they can kind of say, well, I need it right now, but maybe the nurse came in and they're like, boy, that patient's just a pain in the butt. I don't want to have to deal with that patient. Let me just knock him out and get some fentanyl, right? No nurses should be doing that. But you get kind of the idea where nurses may be really more draconian and not give any pain meds. They're like, you're not really in pain, or they might be a little bit more, maybe have a bleeding heart for them and say, you always get pain meds. Here you go. Please have as much as you want. So anyway, so they're obviously within the restrictions of your orders, as you know. But the point being is that IV PCAs also help to limit the total amount of opioids patients get. So if you were to look at someone who had, a typical order set, kind of like the one you're writing for on your prescription assignment versus a PCA, typically they have less opioid use overall when they use the PCA itself. So that's another benefit we're going to see there. So you can do a similar thing, right? So an epidural would be going into the actual spinal column. You would find that they also can control that dose as well. Usually that's a local anesthetic along with an opioid. So for instance, like when my wife was giving, when she went into labor, both times she got a ropivacaine and fentanyl epidural. So that was actually, and what do you think is the benefit of an epidural? Yeah, so it's only affecting certain parts of the body, and it's also a lot less of a much smaller dose overall, because again, you're not getting really wide systemic bioavailability. And we'll talk about this in the OB-GYN section a little bit later on, but it's also nice because if you're giving an anesthetic, which should numb up the patient, do you want the entire person's body to be numb? No, you generally just want the bottom half where all the pain's actually occurring there, and you can actually adjust that based on how the patient's sitting. So if they're a little bit more recumbent, you'll find that the medication will travel further up and affects more nerves, and that will cause further higher effects versus if they're sitting more upright, it will rest lower, and then you'll see lesser effects. But anyway, to go along with that, what you're going to find is that you need to know what kind of the components are of a PCA order to make sure that you don't accidentally give too much or too little medication to your patient. And so typically there's 4 components you'll see to a PCA order. So there's going to be the on-demand dosing, which means that's what the actual patient, when they press the button, what they'll give to themselves. There'll be the basal rate, which means what they're getting continuously. And then there'll be a lockout interval. What do you think that is? It's to prevent the patient from giving themselves too much medication, right? So they can sit there and click it, 1,000 times an hour, but they don't want to get all that medication there, right? So as an example, you'll have, say, like a morphine IV PCA given at 1 milligram per hour. That's your basal rate because it's, how much they're getting every single hour, with a 0.5 milligram on-demand dose every 15 minutes. And typically that 4th component that I mentioned is they will have like a 4-hour maximum, and basically you just do the math to say what's the maximum amount this patient could get, assuming they get every 15 minutes that dose on top of the basal, what's their total amount there. So you'll see those orders pretty frequently if you work in the surgical round, which some of you may go do, right? And here's an example of what one looks like. It's really important in terms of medication security. So for instance, you think the patient can just go in there and just say, well, the nurse hasn't been by in a while and I'm not really getting enough medication. Let me just bump up that on-demand dose a little bit. Or every 15 minutes is really infrequent. Let me just do like every 30 seconds. No, they can't really do that, right? So typically there's like codes associated with these so the patients can't go and kind of muck around with it. Typically these are locked such that the medication cannot be tampered with or acquired by, say, a family member or the patient themselves. And you can see the patient button there on the bottom is what they're actually pressing. And what's nice is that this will record every single button press that's on there. And so for instance, if you see that someone's pressing every 10 minutes, but the medication is only set to come out every 15, what does that sort of tell you? They're still in pain, right? You're not adequately controlling their pain, and so you can take a look at that and say, okay, let's adjust their dose. Maybe we either go up on the basal rate, or maybe we change how frequently they can get their dose, or maybe change how much they actually get on that on-demand dose, right? So there's several ways you can kind of affect that. Now, that's not always to say that you can take that reliably. So for instance, with like little kids, they see a button, they're probably going to press it, right? So for instance, the nurse is like, oh, this kid pressed it like 300 times over this 4-hour period. Like, well, he's probably just bored and just clicking the button because he's stuck in the room and there's nothing good on TV, right? So always take it with a grain of salt there for sure. But also think about like what patients would this not be a good modality for? Sure, so maybe they don't have the manual dexterity, right? What else? They're confused. Yeah, so they're just not with it enough to actually know how to handle it. So for instance, giving it to a 2-year-old, not going to work because they don't understand how that would operate, right? If you have someone who's severely demented potentially, right, or they're so zonked out they would not be able to understand how that works, that would not be a good patient for that. So little things to think about. So as I mentioned, you're going to have that total 4-hour amount as typically a part of that order there. It's just kind of tradition. It's what we normally see. So for instance, if you were to have that same morphine PCA where it's 1 milligram an hour with a demand dose of 0.5 milligrams every 15 minutes. So again, they're getting a maximum of 4 doses per hour, right? So there's 4 15-minute intervals in an hour. Basically just kind of multiply that out. So you know they're getting a total of 4 milligrams over 4 hours, just as their basal rate, and then assuming they got every single one of those on-demand doses, then the total amount would be 12 milligrams. This is handy because it helps us to kind of backtrack the calculations to make sure that it makes sense, and then make sure the patient's going to get the actual amount that they want on there. Sometimes we'll have docs or providers who will not put any basal rate, they'll just have an on-demand dose. We'll see that sometimes, and typically this is our anesthesia people who are starting this. So we'd have the CRNA or the anesthesiologist actually start this, but as the PA, you may be following up on these patients who still have it running, and so you want to be able to address that, make sure that's working well, make sure to see if they're pain controlled, all of that. Right? So what are some adverse effects? So we talked about all the joys of opioids, how great they are, but what are some problems we see with them? Anyone know? Constipation is going to be an absolute guaranteed side effect, especially with chronic use. Everyone's going to get constipated, right? What are some other meds that could worsen that? We talked about other meds that will cause constipation. Calcium itself could do it, right? What else? Also, calcium channel blockers could do it too. Remember we talking about like verapamil and amlodipine and all of those. Those can all cause constipation. Any anticholinergic can do that as well, right? So a lot of combinations of meds these patients may be on will cause worsened constipation, right? So again, when you have a patient who has, say, chronic low back pain, but now all of a sudden they're complaining of abdominal pain coming into the ER, you think, okay, well, is their pain not being controlled with their medications, or is it actually just the fact that they're super constipated? It could quite be that, right? Less frequent, or another thing you're going to see is that histamine release. This is mainly going to be a problem with morphine, right? And what turns into morphine? You guys remember from last week? Codeine does, right? So codeine would carry that same risk there, right? So a lot of people who say, oh, I have a morphine allergy, really, they just get that histamine release, leads to a lot of itching and whatnot. It's not true anaphylactic allergy. Some people may still have that true allergy, but not everyone. How would I treat that? Yeah, I typically give them antihistamine, like some Benadryl or something. But again, what are some other common side effects of opioids in terms of mentation? It's going to cause sedation, right? Well, what are anticholinergics, antihistamines going to do? They're going to cause sedation too, right? So again, you have to worry about causing sort of a synergistic effect here and really knocking your patient out. I mean, really, if you don't want to talk to your patient, give them both, right? And they'll be sleeping quite well, right? But it just depends on the situation, right? So anyway, other things you can see there, delirium. Obviously, this is related to some of the mental status changes you can see with that. The really dangerous thing, though, is going to be this respiratory depression, okay? So CNS and respiratory depression are going to be common things you see, not just with overdoses, but you can sometimes see it if patients are, maybe self-medicating, or maybe they're taking the first time, they may got too big of a dose, things like that. Relatively low risk just with normal dosing, but certainly the respiratory depression, the more you go back on it, the bigger the risk is.
Are there any long-term neurological effects with chronic opioids?
Not that we've seen necessarily, so we don't really see any kind of long-term complication. Normally, if someone can wean off of the opioids, they're kind of back at their baseline as far as I know. There may be, certainly if they had like an overdose and some kind of hypoxic injury, something like that, you can certainly see some consequences of, but not necessarily just normal therapeutic dosing, I wouldn't think. But anyway, so yeah, the respiratory depression is a big issue, and certainly the risk for abuse and diversion. Now, when I say abuse, what does that mean? Could be as a result of dependence, right? They're taking it outside of what has been originally prescribed for them, essentially, right? So again, if you were saying, okay, take this one time every 6 hours as needed, but they say, oh, I'm going to take this every 4 hours, that could be considered abuse, right? Depending on what they're using it for. They may be abusing it for pain control, right, or for euphoria, whatever, but that's still considered to be abuse to some degree because you're going outside of what is actually prescribed there. Diversion, what is that? Could be selling, right? Who does that apply? Just to the patients who are getting the medications? It could apply to family members of diverting medications, right? Who else? We'd have kids sickle cell disease they chronically have pain crises, because their cells just sickle up and then they cause sludging and they cause severe, acute chest pain and all kinds of issues. And we'd have them come into the ER complaining of pain, all the medications they ran out too early, and it was actually the parents who were taking it and selling it or using it themselves, right? So you sometimes see diversion in that case. Who else might be diverting it? How about in the hospital system? Anyone, nurses, pharmacists, PAs, docs, anesthesiologists. I mean, anyone could be potentially at risk for diverting, which is why it's so important we keep tight control on these medications there, because we do know it's at a risk, right? So again, who do you think is the biggest risk for abusing and diverting these medications? Anesthesiology is actually the most likely to actually be abusing the medications themselves when they divert. It's who's most likely to be selling them. The pharmacists actually are. So if you actually look at the data that's out there, we're more likely to be the ones that will actually take it and then sell it for whatever purpose, if make some extra cash on the side, whatever. So there's a lot of things that go into it, right? So that's why we keep such tight controls. Typically, anything you do with a controlled substance, you'll have a witness there that will be able to document on that as well. So for instance, anytime we have a medication's being, like a morphine's being wasted in the machines, we call it Pyxis machine. That's the brand that we use at our hospital. You have to have the nurse who's who's wasting, and then you have to have a witness alongside them, right? Anesthesiology does the same thing. We do the same thing. So anytime we get controlled substances in to the pharmacy, one person will check it in, the other person will do a double check to make sure that all lines up. Then that person puts it into our vault, and then another person will do a final check to make sure that all lines up, to make sure someone didn't say, well, we got 100 in, but I'm going to say we received 75 and then take the extra 25 home, right? So there's a lot of checks and balances put in place there, because that risk for diversion is really big with these medications here, right? We'll talk about some other kind of edge cases there, things like, erectile dysfunction medications or like anabolic steroids and, things like that, but this is probably the biggest risk there. And we look at things too, like, how frequently are people using these medications? If you find that one nurse in particular is always the one getting out the morphine for their patients, and they're saying, oh, hey, you take a break, let me go and give that morphine to your patient for you. Stuff like that could be little triggers of like, hey, something weird's going on here. Let's try to investigate and see if they have any issues. And we've caught a lot of people that way, just looking at their usage patterns. But so anyway, so again, if you're ever concerned about someone or you think they might be diverting, get them help. There's a lot of programs that are in place for impaired providers in order to make sure that they can keep their license. They may not be able to work with controlled substances anymore, but they can still work, right? So that's a possibility. How do we minimize some of these adverse effects? We'll certainly titrate gradually, right? So again, we'll start with full blast doses, kind of work your way up. And again, determine what the cause of the symptoms are, right? So again, if you can have them go to surgery and correct an issue, that's overall going to decrease pain in the long term, maybe use less opioids. We can do things like changing the route or the regimen. Maybe it'll help with bioavailability, things like that. And of course, treat any adverse effects that do pop up. So for instance, with the constipation, we'll talk about means of treating that, right? We'll talk about bowel regimens that can help out with that. Now, some patients just aren't going to really respond well to certain opioids. Like some people, when they receive hydrocodone, they feel sick to their stomach, they hate it. Switch them over to something like oxycodone or hydromorphone, they do totally fine, right? So everyone's going to be a little different in terms of how they respond to this stuff. And just remember that a tolerance will develop to a lot of the side effects, but constipation is always going to stay. So the CNS depression, that kind of lethargy associated with the use, they'll get tolerant to that, right? They'll get used to it. But constipation is always going to be an issue. So when we see that, what we're going to do, and again, most time patients, especially in the hospital setting, if they get put on opioid, they're going to get put on a bowel regimen as well. And so we go with the mush and push strategy. You know what that means? Because we covered GI before. So when I say mush, usually means some kind of stool softener, right? So like a Docusate or something like that. The push is stimulant laxative, right? So something like Senna or something like Bisacodyl, any of those. So you have to use the two together because, yeah, it's all well and good to use one by themselves. They tend to be more synergistic, and you're going to definitely make sure to increase that stool. You at least want them to be stooling one time a day. That's ideal for most patients, right? So, as I mentioned, other things to help out with this, make sure they're getting plenty of fluid, make sure they're getting good non-digestible fiber in their diet. And as I mentioned, that Senna plus DocuSate, Senecot S, that's probably the most common thing you'll see your patients end up being on there, right? Other things you can try using, remember we talked about Miralax, that's becoming more and more commonly used, especially since it went over the counter. That can also be used, it's more of a laxative or osmotic sort of laxative. May not get the same benefits as using the stool softener plus the stimulant, but you can try it, see what the patient responds well to. So what happens if someone takes too much of an opioid and they are CNS depressed or respiratory depressed? What are the three kind of cardinal signs of an opioid overdose? Respiratory depression, CNS depression, find someone passed out on the floor, it could be an opioid, and what else? It's kind of physical exam finding. So the pupils. Talk about pinpoint pupils, right? Those are kind of the trifecta. It's a good board style, easy question you guys can get on the pants, right? Not everyone's going to have those pinpoint pupils, but that's kind of classically what they describe, but don't use that to be your final say in whether or not you think someone's with an opioid or not. However, what you can give them to reverse the effects of the opioids is going to be an antagonist, right? So we know that the opioids work on which receptor, primarily? Remember that mu receptor, right? We're going to have something that will competitively block that, right? We'll kick it off that receptor and then we'll block that effect, so thus the patient should wake up. Has anyone ever seen someone receive Narcan before? What's it look like? Not pretty, right? How fast does it work? Near instantaneous, right? If I had to describe it as a movie, I would call it The Exorcist. It can be really severe if they get too much of it, right? Because what happens when they sit and kick all the opioid right off that receptor, what happens? They immediately go into withdrawal. And normally they're not too happy about that, because especially if they had paid a lot of money for that opioid and they're using it on purpose, and then they were found down by, say, a family member or, say, by a police officer or whoever, they're not too happy about that, right? So little things to think about with this one. So we'll give naloxone or Narcan. That's the most common variety we'll use as an opioid antagonist. This one is not available orally, right? And actually that's why we combine it with buprenorphine, so that way even if you use it orally, no problem, the naloxone doesn't do anything, but if you try to inject it, it actually does work at that point. We will give this intravenously, intramuscularly, or actually more often than not nowadays, we're doing intranasal administration. And so one of the big pushes as of late, as a result of the opioid epidemic, is to increase the availability of intranasal naloxone. And in fact, there's a standing order from the state Surgeon General that says that any first responder can go to a pharmacy and pick up naloxone. Because if you may find someone who may be overdosed on opioid, the potential benefits of saving that life, because again, when you're respiratory depressed and you're not breathing and you're unconscious, time is tissue, right? And the longer they wait there on the floor not breathing, that's a anoxic injury happening to the brain, right? So anyway, so they said, okay, any first responder can go get that. So who's a first responder? Literally anyone. If you think you may have a family member who's on opioids, if you just want to have something in your back pocket, because you never know who you might run into, especially being here on a hospital campus. I mean, like when I went to pharmacy school, we were basically like Rat Shands, Jacksonville, and we were at a building, and basically there's just patients everywhere, right? You're just kind of walking, you're kind of inundated with them. And I mean, there's a lot of homeless people there that were using drugs like on the sidewalk as we were walking to our classes, right? That could be someone you'd respond to, right? So anyone can pick up naloxone. Typically, we'll find either like an injectable form. So here's an example of this one called Evzio, which is an auto injector. It's kind of like an EpiPen for naloxone. It's actually kind of cool because it talks to you. Basically, you take the thing out and it says, okay, place it against the outer thigh, hold it there, and it'll count down with you to make sure it injects all the medication. That's pretty expensive though, so more often than not, we're giving out the IV formulation, but we're giving it with a syringe and a nasal atomizer, right? Anyone know what a nasal atomizer is? What does that do? Yeah, basically, yeah. It's a super fine mist, right? And it can actually allow for better coating on the nasal mucosa, and you get better absorption there, right? Hopefully not their noses all stuffy like mine, but hopefully they get some good absorption there. There's also newer formulations, a little bit more concentrated. That's just a nasal spray that is also available as well. So anyway, so it's very fast acting, especially if you give it IV. And in fact, be careful of the dose you're administering, because it can put that patient immediately into withdrawal. Again, what do the symptoms look like when they're withdrawing? sweating. They're gonna, yeah, their whole GI tract wakes up at the same time, right? So it's gonna be coming out of both ends. They'll be throwing up. They may have diarrhea. What else? Can they die from it? Remember, no opioid withdrawal you don't die from. They're gonna feel like they want to die, right? They're gonna feel very miserable, aggravated. Sometimes they get violent occasionally. I know one person we had that was abusing, I think, methadone. She had overdosed. Came in, we gave her a dose of Narcan to try to wake her up. Immediately sat straight up and said, "Why'd you guys give me that?" We're like, "Because you weren't breathing." She was like, "Whatever, just leave me alone." And then, so, but anyway, other important things to know about this drug. Yes, ma'am.
Is Narcan something that EMS and the fire department have on hand?
Yeah, so for a long time it was just really EMS that had it, right? But what's interesting, if you look at the stats, when you call 911, is EMS the only people that show up? No, you get police to show up, you get the fire trucks to show up. Most of the firefighters are paramedics as well. So everyone shows up at, and it's not always the EMS people that get there first. Oftentimes, about a third of the time, actually, it's going to be police officers that get there first. And so one of the big pushes, especially in Orange County, was to have them have more availability to intranasal naloxone. It's really easy. Anyone can administer, right? It doesn't take a rocket scientist or a medical degree to do so. And so we were training these police officers, and they found that they have more people that are able to basically wake up until EMS arrives, and that way they can provide further care at that point, get them into the ER, and hopefully save a life, right?
So,
Either one.
so say you have a suspected overdose and you give naloxone, but they weren't having an overdose.
Mhm.
What's the side effects?
It's a very good question. None.
No.
Yeah, basically. So if you have someone who you suspected of overdose on an opioid, you administer Narcan, and it wasn't that, it was something else completely, no harm, no foul. And in fact, that's a much better predictor of like actually if that's what caused their CNS depression in the first place, rather than just say if they have a urine drug screen that was positive, right? Because if your urine drug screen is positive, you can be using opioids for any period of time and be positive. If I give you Narcan and you wake up, that's a very good sign that that was specifically what was causing that CNS respiratory depression that we were seeing there for sure. And little kids, we can give this to little kids all day long who are not chronically on opioids. No side effects, no withdrawal because they're not on it chronically. This is just for people who are chronically receiving those opioids who might be at risk for a withdrawal, right? Now, I'll tell you that one of the dosing of it can be really important. So you don't want to just give them full blast necessarily to everyone if you don't have to. So for instance, if you give them just the right amount to wake them up, just enough where the respiratory center starts to wake up, and we know kind of the first thing you'll see them do, they start yawning, right? Because the brain's kind of waking up saying, "Hey, wait a second. There's too much CO2 here. Let's go ahead and get rid of this." And so it takes some nice big breaths. They'll start to yawn. That's a really good sign. You don't need these patients awake necessarily, right? And again, quite frequently they're going to be pretty cranky and withdrawing, so you don't need them to be awake. If they're asleep, that's fine. You just want them breathing, right? And so, certainly you can look at respiratory rate. That can give you some good indications, especially if it's 0, right? But what's something else you can look at that can tell you how well they're breathing? So you're looking for chest rise, things like that. What else can we look for? So you can use pulse ox. Keep in mind though that pulse oxes are they lag behind quite a bit, and so remember that the CO2 drive is much stronger to stimulate breathing than the O2. So typically their CO2 gets up, right? So they have hypercapnia. Is there any way to look for that? You can use an ABG for sure. There's actually an easy way to do it. It's called end-tidal CO2. Have you guys ever heard of that? Right, so it's called end-tidal CO2, and basically it's just it looks like a nasal cannula that you stick in the patient, and it will monitor the levels of CO2 that they're actually expelling. And so if it's too high, then you know that they're not adequately kind of turning over and not breathing well enough. So we will administer this, and usually like 35 to 45 is kind of considered normal. We'll have these patients up 50, 60, 70. We will then administer the Narcan, and they'll start to breathe more, and they'll go back down, right, which is good. So little things to think about with that. There's also some other varieties we'll give as well that only work peripherally, and this is primarily for the GI tract. So for instance, there's a few like methylnaltrexone or alvimapan. They don't cross the blood-brain barrier, so they don't really cause any decreases in analgesia. They don't cause any of that kind of withdrawal symptoms you would think from more of a central perspective, but it does wake up the GI tract. So who might that be good for? Maybe the constipation is due to opioids. All right, so that could be one. Who else? What kind of patient population do you think about, though? Say in the hospital. Yeah, so that post-operative ileus, so they just got out of surgery, they received a ton of opioids, you want to wake their GI tract back up, ever tell you the story about I had this is a long time ago, but there's a parent I was talking to. They were talking about when they had surgery and they're like a little boy, and how long they were in the hospital for. So anyway, so one of the things you want to make sure that your patient is passing gas or at least stooling after surgery, because you want to make sure that they don't have an ileus, right? And so I was talking to this one guy, and he was saying that when he was a little boy, he had appendicitis and had his appendix taken out. But remember, he said that they said it was very rude to pass gas in front of people, and so he was holding it in for like several days, and he didn't know that the nurses were waiting for him to do that to get discharged, and so ended up like extending his stay by like 2 days or something like that. But again, it's not polite to pass gas in front of people, so why would he do that, right? But anyway, this is something we can give to adult patients to actually kind of wake up the GI tract and make sure that they don't have that ileus develop.
So if the patient is like a child, how do they dose naloxone inside? Do they compute it?
It depends on the setting, right? So, for instance, if I have an accidental ingestion, so say I have a little, say a 3-year-old gets into grandma's medication, say grandma had end-stage cancer, she's taking like 80 of morphine several times a day. It's like a massive dose, right? It's not uncommon for kids to get into that, and then, really just be out for the count, right? So, if it's a kid, I don't have to worry about any withdrawal effects, so I can just give them full blast naloxone and wake them up. It's no problem, right? Sometimes, though, if they're on it more chronically, and say, for instance, say they're getting a PCA, say they're post-op, they're getting a PCA, but they accidentally get a little too much, right? So maybe they were a little too aggressive with the dosing. You don't want to reverse all of that, because what's going to happen to the analgesic effects? It's going to go in, the kid's going to be in a lot of pain, right? So sometimes we'll give very small doses, maybe like micrograms of naloxone, in order to help reverse some of that, right? So again, it depends on the indication, kind of what's going on with the patient there. But if it's an accidental ingestion, I give them 4 milligrams, no problem. Try to wake them up, and they're good to go, right? And again, you can always give repeated doses. The other caveat with naloxone I'll mention here is that it's a relatively short acting, right? Within 15, 30 minutes or so, the medication is gone, right? So what is the risk for someone who, say, overdoses on something like methadone? How long does methadone work for? Long time, like half-life over 50 hours, right? So sometimes what you'll have is you'll give a dose of naloxone to a patient, you think everything's good to go, they're waking up, they're breathing, 30 minutes go by, and guess what happens? They go back down, right? They resedate, they stop breathing again. And so that's one of the big concerns, and that's why we educate patients so much. So say, for instance, you have a patient who you're prescribing an opioid to, and you're talking to the family members, and you say, listen, because obviously if someone overdoses on an opioid, are they going to be able to give this to themselves? No, they're going to be knocked out, right? So this is someone else that would be administering it. So say it's someone who's a high risk, you're talking to the family member and say, listen, like, here's this prescription for naloxone, have it filled, have it ready to go. If they do have an issue, make sure, what do you do after you administer it? You make sure they wake up, but then what else do you do? Call 911, right? Because they may think, okay, they woke up, everything's good to go, not realizing they may resedate. So always tell them, call 911. Super, super important.
Is there any limit of doses that you can administer?
No, we can maybe give up to like 10 milligrams, and if they don't respond at that point, then I say, okay, it's probably not an opioid causing the main picture that I'm seeing. It could be like a benzo, it could be something else. But certainly, sometimes we'll have to put them on IV drips if there's like an accidental ingestion or intentional ingestion, because like a methadone overdose, like I've had to give 2 or 3 days worth of naloxone over an IV drip just to keep them breathing essentially. Yeah. So anyway, a lot of interesting things with that. Again, availability is going up, which is good because more people that have it, more people are likely to be rescued with this medication, right? Okay, so let's talk about some other adjuvant, other medications that can be useful here. Some of these we're going to get to when we talk about them in their specific sections. So like when we get to the neuro section, when we get to behavioral, we'll talk more about things like anticonvulsants and tricyclics there. But they are frequently used for neuropathic pain. So if you break an arm, these are not going to be really useful. But if the issue is the specific nerves themselves causing the pain, say due to MS, or due to fibromyalgia, or due to diabetic neuropathies, things like that, a lot of these tend to be pretty good. And the nice thing is they're not opioids, so they don't have all the side effects you're going to see with those. You'll find that different people respond differently to those. Some will get more benefit than others. It just depends on the dose, depends on the pathophys, depends on a lot of different features there. Just to give you an idea, some of the other ones we'll talk about kind of when we get to their specific sections. Things like, if patients have sort of a muscle spasm component to their pain. So for instance, when you have, say, back pain, what is your body's natural reaction to do? When you experience pain, you tense up, right? So when you tense up, what does that probably do to the pain? exacerbates it, makes it worse, right? So you get this kind of sick cycle of pain, spasm, pain, and such that by giving a muscle relaxant, you can kind of relax that muscles and allow them to kind of interrupt that cycle. So that can be useful in some cases there. What do you think corticosteroids might be useful? Decrease that inflammation, that swelling, that heat, all that goes in that pain that can be useful there. We'll talk about other things. How about like botulinum toxin? It's another name for that. Botox, right? What's Botox do? Do you know Botox is the most potent toxin in the entire world? It is the most, like a milligram is enough to kill probably everyone in this room, right? We're given very small amounts, so to paralyze those muscles. So when you normally use it for aesthetics, right? So you can use it for your crow's feet and those 11s you get when you're scowling all the time and all of that. But remember, you can also use it to inject into certain muscles, and it will paralyze them and relax them, right? So we'll do this with a lot of kids with like cerebral palsy. They have a lot of spasticity issues. We'll use that to paralyze certain muscles to allow them to relax and decrease some of that pain. Different options there. And we can talk about marijuana briefly here when we get to it. Here are some examples of antiepileptics that can be good for neuropathic forms of pain. We'll talk more about these specifically when we get into them in the neuro section later on. But this is things like carbamazepine, gabapentin, lamotrigine. These are all going to be agents that are basically helping to stabilize the neurons, so that way they're not firing so frequently, and they're not sending those painful signals up into the CNS. That's kind of how they're working there. Again, start low and go slow, because a lot of these antiepileptics are sort of stabilizing those neurons and making them more difficult to fire. What do you think is a common side effect? If your neurons aren't firing as quickly up in your brain, sedation is going to be a big thing, right? So you see a lot of sedation associated with these, and we'll talk more about that later on. And again, depending on what their job is, depending on what they need to do in a given day, that could be problematic. So we start low, go slow, and remember that will help to minimize some of those effects. So you will get tolerant to some of those sedating effects. We'll talk about TCAs later. These are sort of a old school sort of set of antidepressant medications here, and these are good too if the patient has concomitant depression, because frequently what happens with patients with chronic pain? They get depressed, right? So again, that can be useful if you can kind of get double duty out of one of these medications here. These work primarily by blocking the reuptake of things like serotonin and norepinephrine. For the neuropathic purposes, norepinephrine is really what we're more looking for, and it does help limit some of that pain there. So this could be a useful adjunct in addition to other medication options there. Be aware there's a lot of side effects associated with the TCAs. So there's things like weight gain you can see with this, sexual dysfunction, and then in higher doses you can see things like anticholinergic effects and cardiac abnormalities. Arrhythmias can develop. So not a great set of drugs, but typically these are fairly low doses we're using for neuropathic pain issues. And again, you're going to start low and go slow to see how the patient tolerates it. Now, when I say local anesthetics, these are going to be things like your lidocaines, bupivacaines, ropivacaines. These essentially, anyone know how these work? Because they cause anesthesia, right? They cause numbing effects. Do they like paralyze any of the muscles or anything? No, they just deaden the sensation, right? So basically, and we've kind of talked about some of these local anesthetics before. Anyone remember where? We talked a little bit about the eyes. Yeah, where else? And cardiac. Remember we were talking about our antiarrhythmics, right? Remember class 1B, 1B antiarrhythmics was lidocaine that we talked about there. Remember how it worked? Block sodium channels, right? So remember when we blocked sodium channels, you prevented those action potentials from getting propagated when you had an arrhythmia. Same thing happens here in the neurons. You'll actually prevent propagation of those action potentials, and thus if you have a painful nerve ending that is sending a pain signal up to the CNS, you block that essentially, right? And that's right at the site, right? So again, a lot of these are applied locally, which is why I call them a local anesthetic, okay? Typically, you'll see these used either as like topical products. We'll have things like Imla cream, which is a mixture of lidocaine and prilocaine mixed together. You can typically tell if it's a local anesthetic if it ends with a cane on the end there, right? We have things like lidoderm patches. Those are good for neuropathic pain as well. Basically, apply it over the painful area. The transdermal patch will allow those nerves to not send those painful signals up into the brain. And then we use it a lot for epidural blocks. We use these for local or regional blocks. So say, for instance, someone has a total knee replacement, right? Well, the pain is really only localized to where the actual surgery occurred. So what if we just deaden that area of sensation? What do you think it does to overall opioid usage? goes down pretty significantly, right? So in a lot of cases, there will do things like regional blocks or local blocks, in order to help that. That I think in that the prescription assignment I talked about that NUS procedure, we actually do peripheral blocks where on either side of the chest the patient will get an infusion of a local anesthetic, and that helps to decrease a lot of the pain requirements that they have there in terms of medications. But be aware, you do see neurologic complications of this. Imagine if you were to say interrupt some of those signals from being propagated up in the CNS. What do you think could happen? Remember with antiarrhythmics, we said that any antiarrhythmic can also cause an arrhythmia. The same thing can happen up in the brain, and basically this can cause seizures and other neurotoxicity. So you do want to be careful, make sure they don't get too much. These can also be severely cardiotoxic. So for instance, if someone accidentally gets IV ropivacaine or bupivacaine, the heart can just like shut down completely because all those action potentials are being blocked, okay? So you gotta be really careful with those. Make sure they're only being used locally and not injected intravenously on accident. Okay, so a couple of skeletal muscle relaxants here. We have things like baclofen, cyclobenzaprine, metaxalone, methocarbamol. They all work very similarly, and they all work on the GABA B channel. We haven't really talked about GABA too much, but normally, if you think about the brain as a car, you can think about GABA as being the brakes on the system, right? So basically, if I activate GABA channels, that will allow chloride to flow into the neurons, and what does that do to the electric potential of that neuron? Chloride flows in, so it gets more negative, right? As it gets that resting membrane potential gets more negative, how likely is it to have an action potential? Much less likely, right? Because remember, you have to get to that critical threshold before that sodium channels open up and cause an action potential to occur. By working on certain GABA channels, specifically GABA B channels, and allow those chloride to flow into those neurons, you can help to block some of those skeletal muscles from contracting quite so frequently. And so these are good to help, again, as I mentioned, with that sort of that pain, spasm, pain cycle there, to relax some of those muscles and deal with some of that spasticity there. However, because they do affect GABA, they do cause a lot of sedation. So again, it's going to be another side effect of a lot of these meds. And you can kind of see the trend with all these groups of meds. A lot of them cause a lot of significant sedation. So when you combine them together, again, you're going to see a lot of synergism there. So you want to be really careful with that. Capsaicin. Where do you find capsaicin normally? In chili peppers. Yeah. Anyone know the scale you use to determine the heat of a pepper? The Scoville scale. Very good. So I watched a YouTube video a couple weeks ago about the Carolina Reaper, which is apparently the hottest pepper known to man or woman or anyone. And it was quite interesting. It's this guy, I think he's like in South Carolina or something, but that's his whole life. He just splices and breeds these different breeds of types of peppers together to try to get the ones that are absolutely the hottest possible. But they contain a lot of capsaicin. That's what gives peppers their spiciness. And so essentially what they do is they directly activate the release of substance P. And substance P is what kind of sensitizes those nerve fibers to cause those painful signals to be more likely to occur, right? So one of the things we can do is we can actually administer this on a long-term basis. And you may think, well, that's silly, like patient's having pain. Why would I want to give something that elicits pain? Why would I do that? Because over the long term, you deplete substance P, right? If your nerve fibers are sending out enough substance P and they run out of it, then guess what? The pain overall goes down. So this is really good for like local administration. We see this a lot for like osteoarthritis and other types of pain, where basically as long as they're administering it consistently and constantly for a chronic term, this is actually a very good way to cause some nice analgesia. It will decrease pain sensation wherever it's applied to. However, initially you're going to get a lot of heat along with it. It's going to feel uncomfortable. Patients don't like it from that standpoint, so most patients don't end up sticking with it, which is unfortunate. But you can use it for other things like shingles and things like that. It's like Zostrix is one of the brand names for its capsaicin cream. You can use it for, so a lot of different things there. And so other big things to keep in mind, though, is that, what happens, say, if you're trying to cook at home, you're cooking up with a jalapeno, and you slice it up. What do you got to make sure you do? Wash your hands. What does everyone forget to do? Wash your hands, and then instinctively your eye starts to itch, and then guess what? Your finger goes right in there, and then you immediately regret it, and you get capsaicin directly in the eye. Well, same thing can happen with this, too. So it's really important to make sure that they wash their hands with soap and water. Why include the soap? Capsaicin is very lipophilic, and if you just use water, it's not going to be likely to get rid of it all. So you got to use soap and water to make sure you get rid of all of that, or have them use gloves or anything like that, because again, if they get it in contact with any mucous membranes or the eyes, they will certainly be feeling some of that pain there, right? So you got to be really careful with that. Anyone know what to do if you were to, say, bite into too spicy of a pepper? What do you drink? Why milk? Because it's very fatty, right? You had to drink full fat milk, not skim milk, because all those lipids will then cause the capsaicin to partition over into it, and then boom, now capsaicin not interacting with your mucous membranes, and it will decrease that heat sensation you feel there, right? So that's why they say use something like full fat milk. I've had cases where I've had people who have accidentally got like skin contact. They were really, really sensitive to it. I mean, like basically their skin was turning purple where it was being affected, and they called the poison center, and they're like, I'm in so much pain. What do I do? What do I do? And I say, here, I was like, do you have any, do you have any like full fat milk on the house? And they're like, no, I don't have anything. I said, do you have any olive oil? They said, yeah, I have olive oil. I was like, okay, put that on the area. I'm going to call you back in 15 minutes, see how you feel. And sure enough, the pain had completely reversed. So anything fatty is going to be good because that capsaicin will transition off of that, right? So a little life hack for you guys if you ever have a bad encounter with the pepper. But I mean, that could have been an ER visit, right? So you guys may still see patients like that that are coming in. You're like, what do I do about it? Well, something, give them the fat, right? And that will help out with that. Okay, Tramadol is going to be another sort of semi-opioid kind of medication here. It's pretty weak agonist of the mu receptor, but it also helps block reuptake of things like norepinephrine and serotonin. So it kind of works similar to like a tricyclic antidepressant plus a little bit of an opioid. So kind of get some dual benefits there. And for a long time, this was a non-controlled medication. And so back before, at least in Florida, before NPs and PAs could write for controlled substances, this is kind of their go-to agent for moderate pain because they could prescribe it kind of without any sort of restrictions. They realized, though, that, people can still abuse it. And so it ended up getting switched over to a C4. So there are some limitations to it being prescribed now. And frequently, you're going to see it used along with acetaminophen. So if you see like Ultracet, that's the one with the acetaminophen in it. And again, what's the max amount of acetaminophen they should be getting in a day? No more than 4 grams. And if they have any existing liver disease, even less than that, like 3250 or no more than 3 grams, just decrease it by about a quarter. This one's also really tough too because it's actually not fully reversible with naloxone. So I've had cases where patients have overdosed on this, and we give them naloxone, and they will be breathing well enough, but they definitely don't get that full sort of reversal of their depressed mental status. So it can be kind of tough to work with there. And also you can see things like seizures and arrhythmias because of that serotonin and norepinephrine effects, but not super common. And then marijuana. So let's talk about that real briefly here. So since 2016. We've had medical marijuana in the state of Florida, and so what do we use it for? You can use it for pain, right? What else? Appetite stimulation for cancer patients. Epilepsy, potentially. And really what's interesting, if you read the law itself, they list a whole bunch of things here. So like cancer, epilepsy, glaucoma, HIV, AIDS. I mean, like they list a whole ton of stuff. And then I like this caveat at the bottom to say other debilitating medical conditions of the same kind or class as or comparable to those enumerated for which a physician believes that the use would likely outweigh potential risks. So what does that mean? Anything you want that basically you think, oh, this may work, let's try it out. So it'll give you a little bit of an out there from that standpoint. So, but there are a lot of restrictions to it in terms of who can prescribe this. So currently, PAs are not able to. However, so physicians will go through specific training and licensure in order to prescribe medical marijuana. But I did work with the PA for a period of time where his side gig, because this is kind of a gig economy, so his side hustle that he had was actually working under a provider. He would basically do like an initial screening for the patients and say, yeah, everything looks good. I think you're a good candidate for medical marijuana. And then the doc would just sign off on it, right? So that way he had the PA that was able to kind of see the patients for him. They could see a lot more people. So anyway, so medical marijuana or cannabis, right? So we know this comes from the couple different varieties of cannabis plant there, but most commonly cannabis sativa is a pretty common one there. There's a couple different active components here, right? So we have the main one you think about is THC. It's that delta-9 tetrahydrocannabinol. This is the one that if you were to take a urine drug screen, this is what they're looking for essentially. They're looking for THC specifically, right? So there's that one. That's one that causes a lot of the kind of psychoactive effects. So like the kind of the good feelings you get from it, the paranoia potentially you get from it, all the psychoactive effects is THC, right? There's another compound called cannabidiol, which is thought to be a little bit better in terms of like pain. This is the one we use typically for epilepsy, right? So there's one FDA approved product out there now that's just pure cannabidiol. It's called Epidiolex. It is for 2 very specific seizure disorders, but a lot of other compounds that are out there as well, certainly. Now, where does medical marijuana, where does it actually work at in the CNS? We have cannabinoid receptors, right? Why do we call them cannabinoid receptors? Do we produce cannabinoids? We have receptors. We probably make something that interacts with it, but we realized that when we were studying it, this is the first thing we found that actually activates those receptors. So we call them cannabinoid receptors, right? There's CB1 and 2. Primarily, we're going to focus on CB1 because that's the one we find in the CNS. That's where we get most of the clinical effects we're going to be looking for there. But we know there's a lot of other complex activity that goes on anytime you're using some of these products here. Now, what are the risks of using medical marijuana? Any downsides to it? Memory loss, or you can see some short-term memory loss associated with this. What else? You guys already forgot it all? It's easy. Yeah, so rarely confined. Some patients may develop things like paranoia. I mean, some people, when they smoke pot, they get just like super paranoid. That can lead all the way to hallucinations. People have ended up in the ER before for that. I mean, but overall, from a safety standpoint, like, what do you think about marijuana? Like, maybe like compared to opioids? Quite safe, right? What is the biggest reason why patients are going to show up at the ER due to marijuana? They get behind the wheel of a car and they hurt themselves or someone else, right? So again, there's going to be motor impairment that occurs with that, impaired judgment, and so that's a very frequently, again, there's very few people that show up at the ER and say like, I did too much pot and I'm really high and help me out. That does occur sometimes. I will tell you some examples of why that occurs, but more often than not, it's usually like a trauma call that why these patients are under the influence. Chronically, we don't know enough about this, right? Why do you think chronically we don't have enough information? It's a Schedule I substance, and it's really hard to do good research with this, right? So there's actually at one point there's only one lab in the entire U.S. where they were able to have marijuana that was grown specifically for research purposes, and apparently it wasn't even that good in the first place. But that's all they had available to them. But now, hopefully, as time goes on, as just recreational and medical marijuana becomes more widespread, hopefully we'll get better chronic data there. Now, in terms of dosage forms, how do people consume marijuana? Smoking is probably the most common one people think about, right? So what are some issues with that? Respiratory issues, right? So again, if you have like COPD or asthma, this can all be an issue there. Again, anytime you're so especially if you're smoking a joint, anything that you're pyrolyzing or you're lighting on fire and inhaling, all that hot gas can chronically do damage to the lungs as well, just like smoking a cigarette can, right? So that can be an issue there. Reactive airway disease can be a problem. What are some other routes for administration? So there's edible formulations as well. Or if you know anything about THC itself, it is very lipophilic, which is why you think about marijuana being cooked in like things like what kind of foods they get cooked into? Brownies. You always think about brownies, right? What's in brownies? A lot of butter, right? So again, you like cook the THC into the butter, and then that can be incorporated into the brownies. Again, so that's why you see a lot of edibles, like a lot of confectionaries and things like that, right? Because of that, the lipophilic compounds there. Anyway, so the problem is like when you inhale something, how fast do you think it works? Pretty fast, pretty slow? Quite fast, right? Because it goes from the lungs back to the blood supply, back to the brain. Pretty quick, right? How about when you ingest something orally? Much slower, right? So actually, this is an interesting case series we saw in it was in Colorado where they had first legalized it for recreational use, and they were looking to see if there were any increases in the number of people showing up to ERs because of the increased availability. And what they did find was a big issue is that people did not understand the pharmacokinetics of marijuana. Again, most people who consume drugs, they don't understand the pharmacokinetics, but but what would happen is someone would ingest say a pot brownie, and they would say, after 30 minutes or so, they go, I don't feel anything. So what do? I should take more because I don't feel anything yet, right? So they get the second dose and they wait 30 minutes, and they still don't feel anything. So what do? They take more, right? And then all of a sudden, after about 90 minutes or so, it all kicks in all at the same time. Guess what happens now? they are screwed, right? Because they have way too much THC in the system. They call it couch locked, where basically they would just get extremely high. They'd be stuck in the couch and basically just not able to like get up and do anything, right? Sometimes that would trigger off some of those paranoid delusions and things like that, and that's why people would be showing up to the ERs, because they were just way too high, were not able to handle that, and they were just having panic attacks essentially, and so had to be treated for that. So that was some issues. So that's one of the things. If your patients are going to be using marijuana, make sure they understand that oral dosage forms are going to take, they could take up to 90 minutes or so before they really sort of kick in. So avoid that dose stacking that occurs there.
So if they did come to the ER for like an issue, how would you like support them?
Yeah.
How would you help them treat them?
Yeah, so if they're coming in, depending on symptomatology, obviously, reassurance and try to chill them out a little bit is obviously going to be the best thing. Has anyone been in a busy ER before? How calm is that environment? Not at all, right? So again, finding a calm environment in an ER is tough, and so oftentimes we may use some chemical sedatives that can help us out with that, like benzodiazepines helps to kind of chill them out to some degree. That is usually the most common thing, and then you kind of just support them through it, right? So depending on how long it takes for them to kind of work out of their system, how much dose they had in their system at the time, yeah, it's usually the best thing. So you gotta be really careful from that standpoint. Depending on the dosage form they're going to be using there, and again. I'm trying to think where else I was going to go with that. Be aware, even if your patients are getting just CBD products, so say for instance, if I go to like a smoke shop, just anywhere, right, you can get CBD products, but is that guaranteed to just be CBD? Is there a lot of like FDA good control over the manufacturing processes there? It's the Wild West out there. So you gotta be really careful. If your patients want to use like CBD products specifically, they can still contain contaminants, right? So you can still have someone fail a drug test because they're using CBD and they had some THC that was in there. So again, little caveats you gotta be worried about there.
Did CBD convert to THC too?
I'm not aware of it converting specifically over. I'm not seeing that, but I could be mistaken. If you see something, let me know for sure. But yeah, that's usually what the problem is, a lot of contamination. It was interesting. I was talking to a drug, they're called a medical science liaison. So have I talked about those before, MSLs? So normally if like a drug company, you have like the drug reps, right? Who are just people without medical, like any kind of like healthcare degrees, who will go and try to get someone to buy their drug. You have the MSLs who are like the medical science liaisons. There's like pharmacists or nurses or PAs, MDs, whoever, that work for the company, and they can kind of speak to all the studies. And so I had one of those people come and talk about Epidiolex, which was that CBD only product for pediatric seizures. It was interesting, and she was saying that they had they were approved by the FDA, so they had very clear-cut data showing that their stuff is just CBD. It's quite pure. They had all these other companies that were selling for these like smoke shops and stuff that were stealing their data and said, "Look at our stuff. Our stuff's super pure, right?" And really, it wasn't their data at all. So it's the Wild West out there. So you gotta be really careful with your patients and just be aware of some of the shortcomings, but it can be potentially useful. So let me just finish this up and I'll let you guys go. So anyway, so pain management complex is tough, right? So, and did I skip a slide or two? Is there one hidden there? I did not skip it. So anyway, so point being with medical marijuana, so I think I might have cut out a slide or two, but so who is it good for? Who do you think we should use it for? Anyone? Is it the gold standard for anything? Not necessarily, right? So typically, and then there's been some papers from like JAMA that have come out before, and basically they say, listen, we do know that it does work for some of these conditions. We do know there's some efficacy there. However, if you have other products that work just as well, that are FDA approved, then just go with that, right? It's going to be much simpler from the most part. If those fail, or if your patient really wants to try it, then it's worth a try. That's essentially where most people kind of fall down on the medical marijuana sort of thing today, right? So anyway, so pain management is tough, it's complex. People go and they just do this as their specialty. So again, you're going to be dealing with it in your patients all the time, though, no matter where you work at. And so it's important to make sure you're educating appropriately, make sure you're following, appropriate guidelines where appropriate, titrating appropriately, all these things here. And again, the side effects are the biggest thing you help them manage, especially with like opioids and constipation, all of that. So anyway, so any questions on that? If not, sorry, I went over. I can talk about this stuff all day, but if not, let's do 10 minutes and we'll come back and then continue on. All right, I did have one question on the board. Does marijuana use affect sperm count? I don't know. I've never looked it up. That is literally never been a concern for a patient I've ever had. So I will encourage, if you want to Yes, that is hilarious. Yes. There's a lot of information that's out there, though. I'm sure you could check it out and find out yourself. PubMed is a good place. Just put in marijuana sperm count. I guarantee you at least find something out there that will tell you one way or the other, right? Or at least if it's inconclusive. I do have one thing to mention. Oh, yes, sir.
I have a question regarding the opioid stuff.
Yeah.
One side it said the receptors were for physical dependence, and then I think another side it said another receptor also can like be for physical dependence.
Yeah, it can get complicated between like the kappa and the delta effects there, but again, I think it's just for our purposes clinically, like the mu is the main thing we're really concerned about, right? Because you can have some that will affect kappa and delta to varying degrees, but I think clinically it doesn't really manifest itself, or at least we're not at that depth where we need to really be able to discern between the two there. Yeah, so for general clinical purposes, mu is the one for that. We will have a quiz next week, right? So I think I have an announcement set up to go out and I'll give you some more information, but just to remind you, it'll be just going over that first section, right? So anything on that first PowerPoint is game for that quiz. I think it's like 11 or 12 questions, but you'll have 15 minutes, just like last time. Multiple choice, matching, true, false, that kind of stuff. It'll be through Canvas. Bring a calculator. I put that in the announcement, but there is some easy math that'll be on there, at least for one question. So if you want to bring a calculator, I encourage you to do that. And you're like, oh, what math could we possibly be doing? I don't know. You'll have to figure it out when you get to the quiz, right? But any questions about that? Okay. So imagine you're working in the ER and you have this patient who comes in, say it's like a 23-year-old guy, and he's like complaining of nausea, vomiting, abdominal pain. Yes, ma'am. Not this one, just the first PowerPoint. Yes, ma'am. Yeah. So this guy's coming, he's complaining of nausea, vomiting, abdominal pain. He's had this issue. He's been at your ER, like 6-7 times in the past, say, as many months. He's been to GI. They've worked him up. They just can't figure out why he's having all this nausea, vomiting, right? And you talk to him, and you try to give him some Zofran. Helps out a little bit, but doesn't really make it go away completely. You're talking to him, and in his history, he says the only thing that makes it better is when he takes a hot shower. What do you think it could be? You don't answer because we already talked about it. So this is an interesting one. I think it'll become more prevalent as use becomes more common. You also get from his history that he uses marijuana pretty routinely. They get a cyclic vomiting syndrome that you can get from heavy marijuana use, right? So it's a cyclic vomiting syndrome. The only thing that makes it better is hot water. So if you hear that history of like, yeah, I take a shower, I feel better afterwards, or if like your mom's bringing their teenager in, the mom's like, we're always at hot water, he's taking these really long showers, it could be related back to marijuana use, right? So how do you treat it? Well, you stop taking marijuana and then eventually should help out. It's counterintuitive because actually marijuana itself, it can be an antiemetic, right? It has an antiemetic activity, but in and of itself, when you're using too much of it chronically, you can see this like cyclic vomiting syndrome that can develop there. So in case it ever comes up on your boards or it comes up on your rotations, you can look like a rock star and bust out that little tidbit of knowledge, right? Anyway. It's a couple different names for it, but I've seen like marijuana-induced hyperemesis syndrome or like marijuana-induced cyclic vomiting syndrome. So there's a couple different names you'll see out there. But so a little interesting point you may see to some degree. Anyway, hot showers help for whatever reason. I don't know why, but hot showers are the only thing that makes it better. So that's that key part of the history there. If you hear that, that's the thing to hone in on, right? So you can check a UDS, will be positive for marijuana, and you can say, hey, do you use marijuana? And they'll say probably no, but then you say, you can be honest here. And they'll let you know. I had one kid that came in one time, the mom was really concerned that he was on drugs, and so coming in for altered mental status was the thing on the board. And so I was going to go see the patient because I have my tox background, and so I normally do that in the ER. And your mom's like, he's on something. He's hopped up on goofballs, and just really concerned about this kid. And I walk in, and I mean, like, eyes are really injected. He's just looking like extremely chilled out, and I'm just like, oh, like, well, he's probably just smoking some pot, right? I was like, hey man, what's happened? Like, what'd you do? And he's just like, oh, I'm not saying anything. I was like, I don't really care. Like, I'm not gonna get you in trouble with the police. We just want to know, right? Because in case it was something more serious, we'd have to do more full workup, maybe get an EKG, do labs, all this kind of stuff. He just wouldn't tell me anything. I was like, listen, man, like, here's what we got to do. In case if you're not honest with us, we got to do things like we got to get urine from you. Sometimes we have to like catheterize people for that. We have to get labs. We got to start an IV. We got to do all this stuff. But if it's just pot, you can just let us know, and then we'll be done with it. He's like, it was just pot. It was just pot. I was like, okay, great. And that was it. So I knew. I don't like to coerce patients, but sometimes a little bit of motivated interviewing can sometimes get some extra information out for me. Anyway, so let's talk about the immune response. We've covered a lot of this stuff already, and it kind of bleeds into our pain talk we were already talking about there. So getting into rheumatologic conditions, right? A lot of this is going to be autoimmune in nature, to where our immune system is going to just be really running rampant, right? It's just overactive. It's attacking ourselves to varying degrees, and we'll focus mainly on rheumatoid arthritis for this section here. But you'll find that a lot of the drugs we're going to talk about will bleed over and can be used for many other types of autoimmune conditions, right? So we'll see some of these will come up for not just rheumatoid arthritis, but you can see it for things like, like we talked about a little bit in Crohn's disease and ulcerative colitis and things like that. Lupus, different types of vasculitis. You see a lot of these will have similar effects there. And again, when you have this inflammatory cascade, basically we're seeing that the body's having an inappropriate reaction to some endogenous cell, which normally would not happen, but it's attacking itself, it's releasing all these inflammatory cytokines. We have things like tumor necrosis factors, interleukins, and everything. And we already know that's going to be some of the targets we're going to see with some of our medications when we're trying to deal with this. And again, over time, that chronic inflammation causes damage to the tissue, right? We're going to see things like the lysozymes will start to degrade tissue, especially like in the joints. We can definitely see that in some of the deformities that happens with RA. We know that we're producing arachidonic acid as part of that inflammatory cascade, and arachidonic acid eventually turns into what? Yeah, prostaglandins and things like that, thromboxanes and prostacyclins through the actions of lipoxygenase and through the actions of cyclooxygenase. So we're very familiar with a lot of these inflammatory cascades because we've seen a lot of it already, right? And even then we see things like neutrophils producing H2O2, right? What is that? And peroxide, right? And why is that a problem? Extremely reactive, because what does it break down into? Yeah, it actually produces two hydroxyl groups, right? And so eventually it'll turn into water and O2, right? But before that, it produces these free radicals. When I say free radical, what does that mean? Reactive oxygen species, right? It has a free electron, and it will go and bind up with really anything. It's super reactive, and so it wants to bind to something to get rid of that free electron. And so that frequently means it'll bind to proteins and all kinds of different things and cause denaturation of those targets. And so again, you can see why a lot of this damage that happens here, and that just further propagates that inflammation. So it's definitely kind of a sick cycle that you can see with this. And again, we've seen these inflammatory cascades before. Remember that we will see that whenever we have a chronic autoimmune condition, that things like COX inhibitors are going to be playing a big role here, because we know it's going to help to decrease a lot of the inflammation that occurs due to prostaglandins and prostacyclins and things like that, right? So we're kind of familiar with this one. And again, if I wanted to work even higher up in the cascade, remember our corticosteroids are also going to be a big player here as well, right? And remember, whenever we have patients who are presenting with an acute flare-up of these autoimmune conditions, frequently, in order to knock that down pretty hard, we go with what? Hit them with steroids, right? Because again, that's going to be the most powerful anti-inflammatories we have. And then for more routine use, for more maintenance use, that's where we're going to see more of our NSAIDs and other things like that. They're going to be helpful to kind of keep that immune system in control, essentially. So anyway, with RA, I'm not going to. Have you talked about RA at all? Because you're already very familiar with it. Again, I'm not going to get a lot into the diagnosis and things like that. But again, most of the time, you're going to. And what's the big issue with RA? Why do we care about treating it? It's autoimmune, but what happens in the long term? Like, why do we care? Yeah, it causes a lot of deformation. I have issues with dexterity, especially like the hands can be affected pretty significantly. It can be very painful, right? And there's all other kind of similar things that kind of go along with it. We tend to see that when patients have one autoimmune condition, sometimes they have other ones that kind of go along with it as well. Just based on their genetics and things like that. But again, what you're typically going to see here is that you're going to have this inflammation that's chronically happening within the joint capsule, and it's going to eventually lead to further degradation of the tissue, right? Because we'll compare this with osteoarthritis to kind of see how the two are compared and contrasted to one another in terms of both pathophys, but also in terms of treatment. Because if you think osteoarthritis, like kind of what's the issue with the joints there? Just wear and tear, right? So especially like you can see like patients who are kind of overusing the joint, so say they've been obese most of their life and they're just kind of chronically using it over time, you're going to degrade that. You just basically get bone on bone rubbing together at a certain point. Here again, it's that inflammation. It's again degrading that tissue, eventually leads to those deformations that we see there. And so, I'll show you some pictures here in a moment. Other things that are going to be important are going to be things like your B cells are going to be activated here, again, by the inappropriate antibody antigen response. We'll also see that by affecting different cytokines, things like interleukins and tumor necrosis factors, by interrupting that, you can help decrease this inflammation as well over the long term. And so we'll see there are going to be things that are good for sort of acute treatment or acute management of symptoms, and things that are going to be able to help modify the course of the disease. So have you heard the term DMARD before? What does that stand for? Disease-modifying anti-rheumatic drug. And so these are going to be things that are going to help keep the joint healthier for longer, because by decreasing that inflammation over the long term, you're going to be able to save the joint over a period of time, right? So again, we're going to see they may not be good for sort of acute management of symptoms, but they're going to be good for the long term because they can help to decrease activation of things like T cells and your B cells and whatnot. And we'll see there's different targets that we can shoot for with that. And I'm sure you've heard some of the monoclonal antibodies are going to be useful for that. Also, things like you get a lot of warmth and edema. A lot of it has to do with other inflammatory cytokines like histamine, prostaglandins, etc. That get opened up there. And then even we'll find that the CD receptors can be another important target. If we interrupt that, those cells cannot communicate to one another. Again, that helps decrease the overall inflammatory activation. And so imagine if here you had sort of like normal healthy joint here. Over time, you're going to see that eventually you get degradation of the bone, just really overactive inflammation here. And interrupting any of these processes here, either by, say, binding up some of the mediators, or maybe working higher up in the chain to decrease synthesis of a lot of those mediators, you're going to find that it can be very useful to help decrease that inflammation overall. But really, interleukins, tumor necrosis factors, the CD receptors, those are all going to be really important targets we'll look at in just a little bit. So to compare that with OA, again, we mentioned this is just going to be basically overuse of the joint over the long term, just that wear and tear, where eventually you're going to find, and again, it's a big issue because we have, as you get older, your joints are just going to start to go out, and it causes a lot of disability for these patients here. A lot of chronic pain conditions start out as OA that will be managed with opioids, and we know obviously that's not going to be the greatest thing in the long term, and it causes a lot of need for hips and joint replacements and all of that, right? So again, this is a picture I wanted to show, kind of comparing the two together here. You see what a normal joint would look like versus one that was has osteoarthritis. Again, you have overall just degradation of that the synovial joint. You're going to find that all that the cartilage will break down over time. And again, you can imagine how painful that is, just that bone, those nerve endings just kind of rubbing against one another. Versus when you have rheumatoid arthritis, that inflammation, that heat, that warmth that develops there, the joint gets swollen because again, you're attracting a lot of different types of cells and fluid and all of that to cause that inflammation. So looking at the pathophys there, again, decrease of that articular cartilage leads to injury, it leads to further stress. We'll find that bone breakdown over time. Basically, the chondrocytes will start to trigger off apoptosis, they'll kill themselves off, and again, we're not able to really repair the damage that's done over that long period of time, right? So again, just kind of looking at the picture of between a normal joint to here. Again, by comparing the pathophysiology, though, you see that this is less of an inflammatory condition, even though just that physical rubbing together can cause some inflammation. It's not nearly the same extent as something like RA, and so we'll see how the treatment will differ between the two based on their pathophysiology. But they're kind of useful to talk about together. So our goals of therapy for them: decrease pain, stiffness, reduce inflammation. You can do that if it's present in a way, but it may not always be the case, depending on kind of what the patient's experiencing, which joints are being affected, etc. Typically for RA, though, what we want to do is slow down disease progression, right? Because again, with OA, eventually you can just replace a joint in some cases, right? So if it's knee osteoarthritis, give them a new knee and they're good to go, right? Versus with RA, we can't really replace that, right? There's not a whole lot we can do there. So if we can slow down disease progression, that's going to be beneficial. All right, non-pharmacologic therapy here, again, all this is going to be very synergistic with one another. So again, if you can get patients doing physical therapy, things like that, it's going to be very useful. Do a lot of patients necessarily want to do physical therapy? Why not? Takes time, insurance may not cover it, it's hard work, it hurts, there's a lot of reasons why they don't want to. Obviously, it's going to be very beneficial, though, especially in conjunction with your medications, right? Obviously, surgery if that's appropriate, rest, etc. Weight loss is another big one that can really help out with a lot, especially for osteoarthritis. But to compare the pharmacologic management here, and again, some of these meds we've already talked about, some of them will be new for us. With RA, we're going to see that in terms of chronic therapy, NSAIDs are going to be playing a big role here, right? And again, we'll see there's some issues with chronic NSAID use. We've kind of already talked about those before. We'll hit them again. In some cases, low-dose corticosteroids are also going to be useful here. But again, do we like long-term corticosteroid use? Negative, we do not. But you got to do what you got to do, right? For acute exacerbations, corticosteroids are kind of be the main thing. You're going to see it used, and then our DMARDs are going to be used for sort of long-term control of disease, right? In terms of onset of action, I wonder how long it takes for the DMARDs to really kick in. Like months, maybe a year or two before you really see the full effects of it. So very slow acting, which is why you gotta have all those medications on top of it, like your NSAIDs, in order to help control the symptoms in the meantime, right? Sometimes these knee effusions specifically, you can see things like aspiration of the joints can be very helpful, or you can actually inject corticosteroids into the joint itself. I'll never forget this one time I was in the ER and we had this kid who showed up. He had juvenile idiopathic rheumatoid arthritis, and his knee was just ballooned out. It was just huge, and he's in a lot of pain because of it. And so we actually had the rheumatologist actually come down and do an aspiration of the joint himself. And so we were going to give an intra-articular corticosteroid afterwards. So basically take all the fluid out, relieve that pressure, and then put a corticosteroid in to decrease inflammation. And I'll never forget, just I was in the room with the rheumatologist because I had the drug ready for him, and of course we had to do it under sterile conditions because if you get a septic joint, that's no good. And so I just remember the amount of fluid was being pulled off this kid's knee. I think he ended up having like almost like 200 cc's of fluid just in this knee, right? And that's not a very big joint, right? So there's a lot of fluid there, and you just see the relief on the kid's face as they took that fluid out. You just see like, oh, I feel so much better, not all that pressure there anymore. And then of course the corticosteroid helped out quite a bit too. But compared to osteoarthritis, here we're going to see, while NSAIDs can be useful, there's going to be more of a role to play for acetaminophen. We'll see that from a side effect profile, we like acetaminophen for a lot of reasons there. And then depending on how many joints are really being affected, we'll find that topical analgesics can be useful, right? And we'll see that there's some limitations there. What type of patients do you think topical analgesics are going to be good for? Like a lot of joints being affected, just a few joints? Typically just a few joints, right? Because again, if you have to apply topical medications all over, that can be a problem, right? Patients don't like that. They may not really enjoy having to have that greasy feel from the medications, things like that. We'll see the opioids can be used for acute exacerbations, but we really like to try to hold off on these as best we can because obviously short-term opioid use can lead to long-term opioid use, and we know there's problems there. And then certainly for like knee effusions, you can have aspiration, and corticosteroids can also be used there as well. So talking about the DMARDs, or disease-modifying anti-rheumatic drugs, we'll find they fall into two main categories. There's biologic and non-biologic. What do you think the difference is? 100%, yeah. So monoclonal antibodies, anything that's going to be like protein-based is going to be our biologic agents, and then the non-biologic agents will be anything that are more like, just straight chemical, right? Not an actual protein. That's important because we're going to find that when you want to combine these meds together, there's going to be a logic to that between biologics and non-biologics that we'll look at in just a little bit. Typically, we'll start as early as possible. What do you think that is? And you can try to slow down the progression, save the joints as much as you can. We do see more favorable outcomes because of that. And then in the meantime, for more immediate effects, you want your NSAIDs and corticosteroids that can help out with that, right? So our traditional DMARDs, these are non-biologic. This includes things like methotrexate, hydroxychloroquine, sulfasalazine, and then leflunomide. Some of these we've already seen before. So for instance, where do we see methotrexate last? Talked about it in terms of cancer. Remember how it worked? You're like, oh boy, I repressed all of that. Can't expect me to know stuff from last semester. It all comes back to folic acid antagonist. Yes, very good. Now, if you were to compare the doses between treating, say, leukemia with methotrexate versus RA, how do you think the doses would compare? Which one would be lower doses? For RA, right? So again, these are typically more chronic use. Long-term low doses are being used versus something like cancer. You'd be using a very high dose. Remember, with cancer, you give really big doses, knock the cells down, give them time to recuperate, and hit them again, right? That's cyclic sort of administration. Here, this is more chronic. They're going to be on this for years and years, right? And remember where we saw sulfasalazine before? That was what we saw in GI. Is actually used for like Crohn's and ulcerative colitis. That was some that actually helped decrease some of the inflammation there. So you see there's some bleed over in terms of the effects of these medications and how they're useful for multiple types of disease states. From the biologic standpoint, and again, this is not all inclusive list. These are just some of the more common ones that I run into. But I will tell you this is kind of a blockbuster sort of industry now, and so there's always new monoclonal antibodies coming out here. So with things like Remicade, super common, Humira, very common. Some of the differences here you're going to see include things like, well, do they need to be given IV, so they have to come into an infusion center to receive it? Some of them are much more likely to cause allergic reactions, in which they need to be administered in a monitored setting. Some of these can be given at home by the patients themselves. How often you have to give it. Cost for these is what? Extravagant, very, very costly in terms of medications, because it's hard work to produce a monoclonal antibody like that, right? So we'll see how they're going to work. Most of them are going to be anti-TNFs. I mean, they're actually targeting tumor necrosis factor specifically. We'll see some other mechanisms too, things like abatacept, how that works in just a little bit. Other targets include things like interleukin-6. We have things like tocilizumab, Actimra. We do quite a bit of Actimra over at Nemours. Rituximab, we're working on that one a little bit. And then tofacitinib is actually going to be a novel one, especially in the newest batch of agents we'll look at in just a little bit too. Okay, some other agents, we've tried lots of different things because we've known about rheumatoid arthritis for a long, long time. Is we've used other things like immunosuppressants like azathioprine. You frequently see that used for transplant patients to prevent them from rejecting their organs. Even like gold itself. So if like you had patients who are like extremely wealthy, they could just inject gold into them. Now, but we do have gold-based compounds, and gold itself is cytotoxic. You would actually kill off some of those rapidly dividing cells. However, pretty toxic to other cells additionally. So there's some other ones here you may see used occasionally. Cyclophosphamide, where do we see that last? That was used in cancer too. Remember, cyclophosphamide is one of those alkylating agents, right? Remember how toxic those things were? You could actually use this for like really severe cases of inflammation. We use that occasionally. So the other agents, these are used less commonly. We won't talk about these too much in this setting. Excuse me. So anyway, so the full mechanism for the DMARDs, kind of how they work overall. We know what they target, but we don't necessarily know in the long term kind of what their overall effects are. However, general considerations in terms of use, methotrexate and hydroxychloroquine tend to be the most well tolerated, but they, in terms of efficacy, they're not going to have the same sort of, they don't pack the same punch as some of the other agents we're going to look at there, right? However, in terms of long-term use, that can be a good thing, right? So again, especially if you catch it early on, that can be beneficial to use something that maybe not as strong, but is better from a side effect profile. So for instance, patients starting out early, they can be on methotrexate and corticosteroids, for years and years and not have any further problems, right? For some patients, you may have to combine multiple DMARDs together, and we'll look at some of the logic for that, how we use biologics versus non-biologics together there, okay? And then for most patients, methotrexate is going to be kind of the gold standard. That's what they're going to be on. Again, this is typically pretty low dose. Some patients may be on like weekly dosing. Most patients will be on daily dosing of this. And it's also a good backbone to add on other medications to it, right? Okay, so traditional DMARDs typically have a pretty low, slow onset of action. So it could be 3 to 6 months before you really see it kick in. Could be even longer before you really see full effects. Some of the ones that work a little faster include things like methotrexate, the MTX, that's abbreviated to sulfasalazine, leflunomide, maybe 1 to 2 months or so. So it could be beneficial to get a little better kind of jump start on terms of your actions there. Biologic DMARDs tend to work more quickly, right? Why do you think that is? You had to think about like the mechanism of action for methotrexate. We talked about it being a folic acid antagonist. Are those effects on the cells immediate? Or is there more work on, like, say, the replication of those cells? Yeah, so if you have immune cells around, they're still there, they're still working. They take a while to kick in. In fact, a biologic DMARD is specifically targeting tumor necrosis factor. You can imagine why that works faster, because it binds to that tumor necrosis factor, and guess what? Now it's inactivated, it's not doing its thing, right? So you typically see faster action of the biologics because of that. Overall, though, any of these can result in immunosuppression. So what is the big risk? Infection, right? So for instance, with a lot of the biologics, there's a black box warning on many of them that say, hey, you got to check your patient for TB before you start this. Why is that? They have a latent TB infection just kind of sitting there that your immune system is kind of holding at bay, and then you give them one of these agents that depresses the immune system, what can that TB do? Starts to germinate, it's going to start to grow, and then your patient has tuberculosis, right? Vaccines should be up to date beforehand, right? Because if I depress my immune system, how well will my vaccines work? How do vaccines work? Quick answer is they don't. It's all a government conspiracy. Just kidding. But again, remember, we're giving them either the virus or a piece of the bacteria or something for their body to react to and to generate its own immune response, right? Well, if I'm depressing my immune system and I give them the vaccine, is it going to work that well? Not really. Or if I give them what they call a live attenuated vaccine, something that's like a weakened version, it can actually cause the disease in those patients, right? So you got to be really careful there. That's why we frequently say, well, before you get started on these DMARDs, get your vaccines up to date, right? Make sure you're up to date on those, so that way they kind of work, they work well, and then you can go on the immunosuppressants. And again, kind of what we're talking about here, if it's a killed or recombinant form, those can be given during therapy, but you may see they will not be as effective, right? We talk about the durability of response of vaccines, meaning how long they last for. They could be diminished if you don't have a strong of an immune system to react to it. So that's why we like to give them beforehand if possible. As I mentioned, live vaccines are not recommended because it can actually cause the disease in those patients, just like it would for someone receiving chemotherapy or someone with AIDS, things like that. And then typically they'll recommend starting out even earlier with things like the herpes zoster, giving it maybe at 50 instead of age 60, because we know that risk is going to be a little bit higher for that. Right? So the American College of Rheumatology is at ACR. So getting into it, let's talk about methotrexate. So as I mentioned, we've talked about this before, so you should know at least a little something, or at least hopefully I can tickle some of those memory fibers in your hippocampus and all of a sudden come flooding back, perhaps. Remember, it's blocking the activity of folic acid, right? So you cannot cycle folic acid. What does that do to the cell? We can't produce new base pairs, right? You can't produce, and inhibits that thymidylate synthase ultimately to where it cannot produce new DNA. If you can't produce new DNA in the cells, what happens? Doesn't replicate, may trigger apoptosis, things like that. So because of that, you're going to ultimately slow down replication of these white cells in your system. And again, here's just kind of showing you how it looks. Again, tetrahydrofolate versus what methotrexate looks like. You can see how they look kind of chemically pretty similar to one another. Again, it just kind of is mimicking the structure and then taking its place essentially, right? So what kind of toxicity can you expect to see from that? Well, bone marrow suppression for one thing, right? Why do we use it for leukemia? Because we want bone marrow suppression, right? It attacks those rapidly dividing cells. That's why you can also see a lot of GI effects additionally, right? So you can see oral epithelial ulceration, you get a stomatitis that can develop, GI toxicity, and get diarrhea from this, things like that. Hepatotoxicity is also another big thing you want to monitor for, right? Start monitoring LFTs at the beginning of therapy and then see how they're responding as time goes on there, right? Other things you have to really watch out for is going to be renal function, right? Remember we talked about how renal function is going to be important here because, for instance, if the urine is too acidic, you can actually find the methotrexate will precipitate out. It can actually cause acute interstitial damage, can lead to worsened renal function itself, right? So remember we used to get bicarb with methotrexate and that would help to solubilize it and flush it out. We don't have to do it in this case because we're giving such small doses, but you still want to be careful and look for renal function because if they can't clear the methotrexate, what's going to happen? Levels will build up, toxicity is just going to get that much worse, right? So be really careful with that. Obviously contraindicated in things like pregnancy. Why would that be the case? It's really teratogenic, right? Actually, they use methotrexate to induce a chemical abortion, right? Because it would basically prevent, you think about rapidly dividing cells. A fetus is just a huge amount of rapidly dividing cells if you think about it. So, again, things you want to be really careful of. Obviously, they need, birth control, things like that. It would be useful to administer there. So, methotrexate is going to be, yes, sir.
I just wanted to add that my previous experience with pediatric rheumatology, we gave this drug,
Yeah.
and the most common complaint was vomiting after they injected it.
Yeah, 100%. So you'll see a lot of vomiting associated with this. In terms of like, especially when you look at other cancer drugs, like it's probably not the most emetogenic, but yeah, it's probably one of the more common things. And so how often were they doing the injections?
I don't remember. I think it's usually like once a week or like a couple times a week.
Yeah, so that's the thing too, is you'll see that the dosing will depend on how they want to administer it. I don't know if there's specifically a rhyme or reason. I don't work with that specialty enough to really know. But some patients will be on it daily. Some people may see, oral daily dosing. Some people will be on sub-Q injections, may get it once a week or once every other week, something like that. So it just depends on their dosing regimen. I had one lady who accidentally, she was I think it's tough too, is if they're having to inject themselves. If you think about the manual dexterity required to drop a medication and to inject it, that can be really tough if you have rheumatoid arthritis and your joints are being affected there, right? So that's one thing to consider. But I had one lady who actually called the poison center. She was taking sub-Q methotrexate. She's supposed to take such and such volume per week, and she actually injected like the entire vial on accident. And so we actually had to send her in and actually check levels and make sure she was clearing it effectively because she just had way too much all at one time, right? Anyway, so looking at this, there's a lot of different dosage forms, as we mentioned, PO, sub-Q, IM, just depends on the situation there. As far as monitoring goes, you got to watch your CBCs, your LFTs, serum creatinine certainly at baseline. A lot of these patients tend to be older, and so again, you want to watch that renal function. If it's pediatrics, probably not so much, but be cautious with that, right? Now, why would I give folic acid along with this? Doesn't bind up the folic acid. Remember, it prevents our or prevents cells from using that folic acid from cycling it through to produce new base pairs and things like that. We give this again. Remember, we talked about the rescue medication you would give for methotrexate last time. You can't give folic acid. We give folinic acid, already activated form. Here, we're just kind of giving this just to kind of help make sure our normal healthy cells are going to be helped out. Do we have any clinical studies that say this actually is going to help prevent any side effects? Not necessarily, but it's probably just good practice. And again, who couldn't use a little bit more folic acid in their diet? Right, exactly. So it's probably not going to be a big deal. But you may see they may do it once daily, may do it once a week. Just depends on the situation. Okay. Up next, we have leflunomide. This one is going to be working kind of similar to methotrexate, just through a different mechanism. Ultimately, it's inhibiting pyrimidine synthesis, so it's preventing those white cells from producing new DNA and replicating there. It actually is a prodrug. Remember what a prodrug is? As it gets activated as it goes to the liver, it turns into the active form there. We'll talk about that a little bit later on in a different disease state in neurology. But again, this one is also going to have similar efficacy to methotrexate, fairly good from a side effect profile as well. Again, this is another non-biologic, so it can take some time to kick in, but this one's a little bit faster. Maybe within a month or so, you should start to see some benefits. With this one here, you're going to see that diarrhea is probably the most common side effect you'll see with leflunomide. And again, this can be hepatotoxic, so you do want to watch out for that. This one's really interesting from a teratogenic standpoint because it undergoes enterohepatic recirculation. Do we ever talk about that? What does that mean? But sent out to the biliary tract and then gets reabsorbed from the GI tract, right? So ultimately, what does that do to the half-life of the drug? Extends it extremely long, right? So actually, in order to get levels down to where they're not detectable, it takes months in some cases. Which means if you have someone who wants to get pregnant anytime soon, that can be a really big problem because the stuff's teratogenic, so it's going to be sticking around for a long, long time. And so sometimes what we'll actually do is give a drug cholestyramine. We've talked about that before. You remember what kind of a drug that is? It's a bile acid sequestrant. It actually can bind up the leflunomide in the GI tract and prevent it from being reabsorbed. So sometimes we'll do a cholestyramine washout, and that will help to speed the decline in those levels such that the patient can potentially get pregnant at that time. So anyway, those are typically things you want to be cautious of. Next we have hydroxychloroquine. This is one you see a lot in our sickle cell patients as well, but we can use it as a DMARD here. This one's probably like the wimpiest out of the non-biologic DMARDs in terms of efficacy and also in terms of toxicity, so it's probably the best tolerated, even though it would be the least effective, but could be useful either as an add-on agent or just for a very mild disease, maybe caught it pretty early there. Does a couple of different things. It can help to inhibit neutrophil locomotion, which means that it can't travel to the site of inflammation quite so well. Will help to impair some of that complement system from kind of working and helping to prevent those reactions between the antigen and the antibodies, sort of that inflammation that is sort of kicked off by that complement system there. Will take some time to kick in. And again, no real significant myelosuppression, no good hepatotoxicity and renal insufficiency. So overall, less monitoring, but again, remember it's going to be less effective overall as well. Some things you may see with it, this is actually a case where you can see increased skin pigmentation, so you can actually see a little bit kind of this graying or darkening of the skin there. So again, if you notice that, it may be something that may be slowly reversible or irreversible depending on how long they've been on it for. So something to kind of consider. Next up, we have sulfasalazine. We talked about this before. This one actually gets broken down by colonic bacteria, which makes sense why we're using it for Crohn's disease, as we saw last semester, I think. But sulfapyridine 5-aminosalicylic acid. Now, salicylic acid should be anti-inflammatory, right? Because it works like what? Like aspirin, right? Like other salicylates. So this is going to be good as a immunomodulator. Actually help to inhibit TNF to some degree as well, and helps as kind of a free radical scavenger. So it kind of helps us scavenge up those reactive oxygen species and prevents them from causing further damage. Again, 1 to 4 months or so in terms of onset of action. So with this one, a lot of patients are going to experience a lot of nausea, vomiting, diarrhea, which makes sense because it gets activated there in the colon. So you do want to watch out for things like their elevated LFTs, look out for hair loss, things like that. Again, typically you're starting relatively low dose and titrating up to see what they can tolerate overall, and then mostly supportive care from that standpoint. Less leukopenia, less thrombocytopenia than something like methotrexate you would typically see there. Be careful though, because you will see some interactions in terms of like antibiotics. So for instance, if I give someone antibiotics, how do you think it might affect the drug? If I give her something like gut bacteria, it may not be available to activate the drug, right? So in some cases, they may make the drug less effective. It can bind up with things like iron, so be aware of that. And remember, this is another one of those agents that can turn the stools and the urine sort of an orange, yellowish kind of color. And again, if you saw orange urine, probably be concerned about things like bleeding potentially, so just warn the patients about that. So tofacitinib, this is actually the newest out of the bunch here. I think there's some other ones that have come out that are in a similar class. This is kind of the most representative one. So basically this is what we call a JAK inhibitor. And so it gets a little complicated in terms of the mechanism here, but it's nice because it's pretty specific in terms of how it actually works. Better from a moderate to severe RA. And so while this is not specifically a traditional biologic agent, we will see that it has such good immunosuppressive sort of effects that we kind of consider it in the same realm in terms of efficacy as a monoclonal antibody. Nice thing though is actually going to be an oral agent that we can administer. It's not going to be something you have to inject, so that's kind of one of its big selling points there. Anyway, if you remember our tyrosine kinase receptors, remember those are really important cell signaling molecules. So typically they get activated on the cell surface and then see some effects as they travel down and actually affect the DNA to cause activation, transcription, and things like that. And so here what we'll find is that by inhibiting this system here, by inhibiting things like interleukin-2 from affecting these JAK proteins, which you can see right here, it actually helps to prevent these eventual translation and transcription of those genes. So, as I mentioned, really nice because it's available orally. You can use as monotherapy or in combination with other DMARDs, so it can be either an add-on agent or used by itself. But we don't like to combine it with other biologics, mainly because of the fact that the immunosuppression would be pretty significant, so you don't want to cause too much immunosuppression, risk for infection to go up too much there. It is metabolized by CYP3A4, so if you have any inhibitors on board, you may want to reduce your dose in those situations there. Another example, you want to test for TB beforehand to make sure they don't have any kind of latent infection that you may activate by giving the drug here. And then there is some risk for obviously serious infections, so I put a black box warning on there for that. Could cause things like lymphomas, other malignancies, more long-term use, so we don't know necessarily, what the actual rate is, but fairly rare for the most part. So any questions on the non-biologics? I'm going to go ahead and cut it there. Do you have any questions at all? Let's see if there's any questions over here. Let me get rid of this one because I think we sufficiently answered that one for our purposes. If nothing else, remember the quiz will be next week. If you have any questions in the meantime, let me know. It's just over that first PowerPoint. If not, I will see you guys next time.